Ashley. Well, good afternoon, everyone, and thank you so much for taking time to join us for this webinar. We're so glad that you're here, and we hope this session will be helpful for you and your family. Again, my name is Grant Smith, and I'm a palliative care doctor at Stanford. And today I'll be talking about planning ahead and making decisions about your future healthcare in the event you were to become seriously ill. While the coronavirus pandemic has definitely made all of us more aware of the possibility of becoming suddenly serious ill, the types of questions this pandemic is raising are really questions that we actually could have had to face before this pandemic. And these types of decisions are also ones that we may have to face in the future, even after this pandemic. So for those of us who are living with a serious illness or underlying health conditions, the possibility of getting more ill or more seriously ill is one that's heightened, again, even outside of coronavirus. And for those of us who are relatively healthy or don't have underlying health conditions, we too are never guaranteed continued good health. And whether that's through an accident or an infection, the possibility of developing a sudden serious illness is present. So with that being said, though, we know that coronavirus has really brought up additional questions and brought some of these questions to the forefront of a lot of people's minds. And so I'll aim today to help address some of those concerns. Before we jump in, I just want to give a quick intro about how to use the webinar features of Zoom. So if you'd like to ask a question, please click on the Q&A box in the bottom control panel. This will open a new dialog box for you, and you can type in your questions there and press send, and that will submit a question. And then as the questions are submitted, you'll be able to see them in that Q&A box. You can read through these and like a question by clicking on that thumbs up icon below the question. And when you like a question, this basically votes for the question. And at the end of this session, myself and Dr. Tuderberg will try to answer the most popular questions from the webinar. Overall, we're not going to be using the chat or the raise hand functions, though. So really use that Q&A part in order to ask your questions. And again, we'll answer those at the end. I'd like to begin by just taking a moment, though, to acknowledge that there is a lot of stress and anxiety going on right now, and that many people may be feeling that, especially during this time of uncertainty. And I know that thinking about this topic in particular, the possibility of possibly getting seriously ill, can also be anxiety-provoking and difficult to think about. So what I'd like for us to do together, actually, is just to take a moment to take a deep breath in and out, and just bring ourselves to this space, into this moment, and acknowledge that by participating today, we're going to be adding to our ability to be prepared. And that additional preparedness, I hope, can help alleviate some of that anxiety and uncertainty many of us are feeling right now. I do want to say that here at Stanford, we're calm, we're focused, and we're ready. And that's what I really hope for you all too, is that you all feel that as well. With that, as a roadmap for today, here are some of the things we're planning to talk about. Really is what is advanced healthcare planning, including what questions should you and your family be considering right now. We'll talk about some special considerations during COVID-19 or coronavirus. And finally, we'll talk through a how-to guide to get started. So what is advanced healthcare planning? It really is about making decisions about the healthcare you would want if you were to become seriously ill or unable to speak for yourself. These are your decisions to make, regardless of what you choose for your care. Our goal today is really to help raise these questions for you and your family and provide you with some information to help inform those decisions. But again, ultimately, these decisions are up to you, and our job is to really support you in those decisions. You may be wondering what types of future healthcare decisions are we talking about, and we'll talk more about these throughout the presentation. But we'd like to discuss a few now so it helps you understand what we're talking about. One of the most important steps you can take is to choose someone who'd be willing and able to represent your voice and your wishes if you were unable to communicate your wishes. However, in order to help them to do this, to represent you, it's really important that you take time now to think about what you would want for yourself if you were to become seriously ill or unable to communicate to that person. I recommend starting with asking yourself the question, what is important to me and what makes life worth living? I know this is extremely broad and can feel really confusing, like what do we mean by that? Let me use myself as an example actually to help explain what I mean. So when I think about for myself, what really makes life worth living? The essential thing that I feel like I couldn't live without is the ability to recognize and meaningfully interact with my friends and family. If something happened to me and it was clear that I couldn't do that or I couldn't get back to that, I wouldn't want my family or my doctors to do things to artificially prolong my life, like keep me on a breathing machine or a ventilator, or to do CPR or chest compressions to try to restart my heart if it were to have stopped. Because if it wasn't going to get me back to those things, I wouldn't want that. Other people, though, prioritize different things and feel differently. For example, some people may feel that being able to care for themselves independently is critical to them, and they may not want their lives to be artificially prolonged if they had to be dependent on others for their care. And yet other people may feel that simply being alive, regardless of how other people may perceive their quality of life, feel that that is a life worth living and would want to do everything to prolong their life as long as possible. What you value and what you prioritize, again, could be really different depending on where you are with your health and your health status. For example, you may value things differently if you were seriously ill or even at the end of your life. Your values might depend on how likely you are to recover or how likely you are to be able to live longer. Just to provide another example, some of the people who I meet who are near the end of their life, who have an advanced illness, like a cancer that may have spread to multiple parts of their body, they may prioritize being comfortable or being at home as being even more important than living as long as possible. They might choose not to pursue certain treatments or even to come to the hospital, even though that could help them to live longer, but they may have concerns that the burdens of those treatments may not be worth going through. And again, other people in the exact same situation who may be facing the end of their life from an underlying illness may feel that living as long as possible is extremely important, no matter what the quality of life is, and would choose to go to the hospital or have procedures for the chance to live longer. When you think about these different scenarios and think about your values, your healthcare providers often want to know if there are limitations to life-prolonging or life-sustaining therapy that you would want. The default in the American healthcare system is to do everything to prolong life. And for a lot of people, that's a really good fit. However, it's not always a good fit for people, especially those for whom the likelihood of recovering may not be very good, or where the interventions may impose a burden on someone's quality of life that they would find unacceptable. Again, how you feel about this may depend on the context, such as your health status and the likelihood of whether or not you would be able to recover. I do want to say that if you are in the hospital or need to go to the hospital, it's very likely that you'll be asked about your preferences around receiving cardiopulmonary resuscitation, or CPR, or being put on a breathing machine or a ventilator. Again, CPR refers to having chest compressions, which is when someone pushes on your chest to try to pump your heart or deliver shocks to your heart to try to restart it in the event it stops. I want to say these are some very heavy questions and questions that many of you may not have thought about before. I think that thinking about these decisions can feel pretty intimidating, and it's often really hard to know where to start. So what I'd like to do is just offer a model that I use actually when I'm teaching medical students, residents, and fellows about advanced healthcare planning. And I call it the tree of life. And if we think about our healthcare decisions as a tree, the roots of that tree are really your health status. Your health status includes things like overall, how healthy are you? What medical conditions do you have? Are these serious conditions? Could they be life-limiting or life-threatening? And if they are life-limiting or life-threatening, have you talked with your doctor at all about your prognosis or how long they think you may have to live. Having a good idea about where you are with your health can be really important, again, to framing your thoughts. People who are healthy and expect to live many more years may value things differently than those who expect that their lives may be shorter. I think we all would feel really different if we knew that we had 6 days, 6 weeks, 6 months, 6 years, or even 6 decades to live. We would value things differently. The trunk of the tree, again, which is informed by your current health status, is really the goals, values, priorities that are most important to you. Another way of thinking about this is asking yourself what matters most or what makes life worth living, like we talked about before. And then finally, at the top of the tree are the branches. And those are all the medical decisions that could present themselves. Things like being put on a breathing machine or a ventilator, getting CPR, going to the hospital, or choosing to prioritize your comfort or treating symptoms over pursuing life-prolonging treatments. In my experience, these decisions up in the branches of the trees can become a little bit less overwhelming and less difficult when the roots of the tree and the trunk of the tree are really solidly in place. I'll also say that as part of advanced healthcare planning, we know that health status and priorities can change over time. So thinking about what your tree sort of looks like today may be different when you think about what it would be like if you were to be more sick than you are now. Again, I know this is a lot, so why don't we talk about 2 examples to help me explain sort of how I use this tree. And again, I'll use myself as the first example. So for the roots of my tree, I'm fortunate to be healthy. I don't have any underlying medical conditions, and I can reasonably expect to live another 30 or more years unless something unexpected happens. For the trunk of my tree, as I mentioned, being able to recognize and meaningfully interact with my family is what's most important to me. So for my healthcare decisions, I would really be willing to accept just about any life-prolonging therapy that was offered, as long as my doctors felt like I would be able to get back to the point of being able to interact with my family. However, if I were so sick that it was clear that I wouldn't survive the illness, or I would be so debilitated or changed from my illness or injury that I couldn't get back to interact with my family, I wouldn't want heroic measures like CPR or a breathing machine to be continued. And I really would want my family and my doctors to focus on making me as comfortable as possible for the time that I have left. Meaning I would want them to focus on treating the symptoms that were happening rather than just focusing on treating the underlying illness. Let's think of another example. This is based on patients who I've met living with a serious illness. Let's consider a woman who's 86-year-old and has cancer that's spread to multiple parts of her body. Let's say her doctors have told her that even with treatment, she may only live for 6 months or a year. She's been hospitalized in the past from complications of her cancer, and after each hospitalization, it's taken 1 or 2 months to get back to recover from that hospitalization. Given her health status and her prior experiences, she now prioritizes, or the trunk of her tree is really about being at home and trying to stay out of the hospital, even if that means she may not live as long. She would say that she wants to focus on being comfortable and having quality time with her family. So based on these goals, if she had to approach the branches of her tree, that she really would be willing to do whatever treatments to help prolong her life as long as they could be done at home. But if she got so sick she needed to come to the hospital, she would prefer that we focus rather on her comfort and being at home. And she wouldn't want things like CPR or to be put on a breathing machine, given her underlying illness. There are, of course, many, many shades of gray between these 2 examples, but I think that these examples can help describe how we use our health status to help inform what's important to us, and then to help making those healthcare decisions a little bit easier and more approachable. Let's move on to talk about some of the special considerations during COVID-19 or coronavirus. In particular, I'm going to describe some information about COVID-19 that I think could help with that bottom part of the tree, really thinking about our health status, which could influence our healthcare decisions if we were to become sick from coronavirus. And before I continue, I just want to acknowledge that I'm not an infectious disease doctor or a coronavirus doctor. I'm not Anthony Fauci. But like many physicians around the country, I'm doing my best to understand the data we have now and know that with this rapidly evolving situation, things can change, and having an accurate picture can be a little bit difficult. The information I'm going to provide is really about populations. So this speaks to kind of the overall population. But for each of you, on an individual basis, you'll need to consider where you are with your own health. And if you're not sure, talking with your primary care doctor or your other specialty doctors could really help out with that, and they could help you know what coronavirus might mean for you and your health with a lot more specificity. It's also important to start by acknowledging that the overwhelming majority of people who get coronavirus will recover on their own. Data from China and Italy suggests that 70 to 80% of people have either no symptoms or a mild to moderate disease course. I do want to say that because data is still emerging, I'm going to talk about people who have died from coronavirus. And to talk about that, I'm using what's called a case fatality rate. A case fatality rate is simply the number of people who have died from coronavirus divided by the number of people who have tested positive for coronavirus, or the number of cases. As you might imagine, these percentages can be heavily influenced by our ability to test and identify all the cases. So for example, if you're only able to test individuals who are very sick and at a high likelihood of dying, your case fatality rate could be quite high, compared to if you're able to test everyone in a population and identify all the cases, that percentage could be lower, even if you were looking at the same illness. But looking at these rates based on the WHO and Johns Hopkins University information, the case fatality rate for the world population is around 5%, with ranges from 3 to 7%. In the US, and actually mirrored here in Santa Clara County, the case fatality rate is around 3.4%. Within these overall case fatality rates, we know that there's great variability between age groups. And we know that older adults are at a higher risk of dying from coronavirus, with case fatality rates for individuals aged 70 to 79 ranging from 8 to 13%, and individuals aged 80 years or older ranging from 15 to 20%. We also know that older adults are at a higher risk of needing admission to the hospital or needing admission to the intensive care unit for things like closer monitoring or mechanical ventilation, which means being put on a breathing machine or a ventilator. And the next numbers are fairly rough estimates and based on some data that gave pretty large percentage ranges, but very roughly for patients who are age 75 years or older, about half of those individuals seem to be able to recover at home, and half of those individuals age 75 years or older who get coronavirus end up needing admission to the hospital. Of those who are admitted to the hospital, about half of them need to go to the intensive care unit for a higher level of care. We also have seen that individuals who have underlying conditions are at a higher risk of dying from coronavirus. This data comes from a study in China where the average case fatality rate was 2.3%. So you can see that individuals who had cancer, underlying respiratory disease, diabetes, were at a higher case fatality rate than that 2.3%. Although again, I would just remind you that the worldwide case fatality rate has been around 5%, and then again here in the US and in Santa Clara County has been around 3.4%. The trend that older adults and individuals with underlying conditions are at an increased risk for dying from coronavirus is supported by our local data here in Santa Clara County. These graphs represent individuals who have died from coronavirus. On the y-axis or the vertical axis is the percent of deaths. On the graph on the left, this is breaking down those deaths by age. You can see that well over half of the deaths have been in individuals who are age 71 years of age or older. The graph on the right shows that 80% of the individuals who have died have had one or more pre-existing condition. So far, we've really been talking about a perspective of the overall population. I now would like to focus on sort of the title of this talk, which is, what if I become seriously ill and discuss what we know about the smaller and quite a bit smaller population or subset of patients who get so sick that they need to be in the intensive care unit or need to be on a ventilator. This is data from Seattle and the United Kingdom that really suggests that among those who need the ICU with COVID-19, there's an overall case fatality rate of about 50%. Those who are age 70 years or older have a higher case fatality rate that approaches 68%. The population slightly younger than that, ages 50 to 69, have a case fatality rate of 46%. And those younger in the 16 to 49 age group have a case fatality rate around 24%. The pie chart on the right is the data from Seattle, again showing the 50% case fatality rate for individuals in ICU. This study followed patients for 14 days or 2 weeks from the time they started in the ICU. 21% of those patients were able to be completely discharged from the hospital. 17% were able to be discharged from the ICU, meaning that they were still needed to be in the hospital, but they did not need that level of care in the ICU. And then 12% were still on a ventilator even after 14 days in the ICU. So that part of the population is a little bit unsure of what their outcomes will be. I also want to bring up a final consideration to know about is that if you or a loved one were to be in the hospital, there are strict visitor policies in place. Currently at Stanford, the policy is no visitors, except for the following exceptions: individuals under age 18, individuals who have disabilities or need a caregiver in order to receive their usual care, and these are pretty extraordinary circumstances when that's needed. If they have urgent legal issues, or if patients are at the end of life, meaning a likely prognosis of less than 48 hours. We'll talk more later about some strategies for planning ahead and preparing for this in the event you or a loved one needed to be in the hospital. Again, this has been an incredible amount of information, and thank you for hanging in there with us. Continue to ask your questions in the Q&A section, and we'll try to answer as many of the most popular questions as possible at the end. Given all this information, though, let's consider together, what does all this information mean for you? And I would say, let's take this information and go back to that tree of life model and think about the roots of our tree, really understanding our health status or prognosis and what could happen if we were to become ill with coronavirus. I think for many of us, this information probably reinforces that we would want all life-prolonging therapies if we were to become ill. However, for others, this information might raise serious concerns about whether pursuing life-prolonging therapies, going to the hospital, aligns with the goals and values and things that are important given your underlying health status. I think we all may feel differently when seeing the same information. And again, our hope today is not to direct people to any particular decision, but really to help provide information and raise questions to help you be prepared. I'd like to add that no matter what care you choose to pursue, your healthcare team is going to be here to support you. Whether it's at home, in the hospital, in the intensive care unit, or on a ventilator, we will all be working very hard to continue to provide care that meets your needs and meets your goals. I do want to say that if at any point you or a loved one, after assessing your health status and values, decide not to come to the hospital, or would prefer not to seek ICU level care or to be intubated, or if in the event you were to get seriously ill, we're committed to supporting you. If you're at home, you can get support from your primary care providers or your specialty doctors through telephone calls and video visits set up through the computer. In addition, our palliative care team at Stanford specializes in treating symptoms associated with serious illness, like shortness of breath or pain, and we're available through telephone calls and video visit support. If you're a patient at Stanford, you can ask your primary care doctor or other doctors to submit a referral. And if you get your care outside of Stanford, talk with your primary care doctor or other doctors if they work with a palliative care team that could help support you. I also would say that individuals who feel like they want to prioritize their comfort or alleviating symptoms of their illness above life-prolonging therapies, you may be eligible for a service called hospice, which provides care in the home. Hospice is designed to provide care for people who are in the last phase of their life and are estimated to have a prognosis of 6 months or less. And again, who really feel like focusing on treating the symptoms or focusing on comfort is most important to them. Your primary care doctor or other doctors can help you connect to that service if you feel that it might be right for you or your loved one. I also want to say that if you come to the hospital and feel like you are okay to be at the hospital, but don't want to go to the ICU or wouldn't want to be intubated if your clinical condition were to worsen, we also are able to provide care that focuses and prioritizes your comfort in the hospital as well. With that, let's move on and talk about how to get started with advanced healthcare planning. We're going to learn about some action steps that you can take so that you and your family can feel more prepared for the future. The first step is really talking with your doctor. Talking with your doctor is a great place to start as a way to get at the roots of your tree of life. Your doctor can help you consider your current health and put that into context with coronavirus and give you personalized feedback about your situation. A few questions that you might want to ask could include, how do you think things are going with my overall health? Do you think that my health would affect the way I would do if I were to get sick with coronavirus? Or even if I were to get so sick with coronavirus that I need to be in the hospital or even on a breathing machine, do you think I'd be likely to recover? Those are all questions that your individual doctors will be better able to answer because they'll know your health status. I'll remind people that you can contact your healthcare providers, certainly by calling their office. Here at Stanford, you can use the My Health online portal to send a message to request a visit. And for those of you who are patients at Stanford Primary Care, please check your My Health messages for more information about some follow-up opportunities to discuss advanced healthcare planning. The next step is really to think about what matters most. So as we discussed before, what you value may be informed by your health status, and asking those questions about what makes life worth living can be really helpful to have clarity. Some people find it helpful to think about what worries they may have. Are you worried about being in pain or having shortness of breath? Do you worry about being alone? You may want to consider potential trade-offs. What are the things that you feel like you can't live without? Are there certain capabilities or functions that you can't imagine living without? I also want to say again that here uncertainty is really okay. These are difficult questions, and this is just to get things started for you. The third thing that we would recommend is to choose a surrogate decision maker. That's someone who could step in and make decisions for you in the event you're unable to make them for yourself. We really recommend this because it can be very hard to try to think through every possible scenario that might come up. And having a person who knows you well and knows what's important to you can help make sure that your values are honored when you're not able to speak for yourself. We encourage you to think carefully about who you would choose as your surrogate. Do they know what you would want? Can they essentially act as your voice when the time comes? Also, are they someone who's available? Will they pick up their phone? Will they show up? That's an important part of this. Will they be able to hold on to your values, even if that means making a difficult decision? The fourth step we would recommend is completing an advance directive. And it's really one way to get your thoughts in writing. An advance directive is a written document that helps you tell doctors and your loved ones how you would want to be treated if you couldn't speak for yourself. The advance directive form also includes assigning your surrogate decision maker, so that's a good place to document who you'd want to make decisions for you. And there are multiple different advance directives, and we have some more resources for you that I'm going to share here. One of those resources is the Conversation Project. At this website, there's really helpful tips about how to start talking with your family about your wishes. I would also recommend Prepare for Your Care. This is a website that provides an advance directive that's very approachable, and it has a lot of videos that help walk you through how to complete an advance directive. I'd also recommend our Stanford Palliative Care Advanced Care Planning website. You can find more information about advanced care planning and additional resources there. And for all these websites, we'll be emailing everyone who's registered for the webinar with these websites, as well as our evaluation for the webinar today. I'd also just like to provide a little bit of practical advice for preparing for serious illness. As we mentioned, there are pretty strict visitor policies in many of the hospitals. So now would be a good time to set up a video chat app with your loved ones. Whether that's FaceTime, Skype, Zoom, Google Duo, WhatsApp, there's a lot out there, but whatever works sort of best for you and your family. But now is a good time to test it, call your loved ones using it, and make sure that they know which buttons to push and how to make it work for them. It's also a good time to plan ahead for your medications. Keep a list with you, keep a supply, call early if you need refills. Make a backup plan for your pets, who could take care of them if you were to get ill. Plan for your bills, who could help manage your finances, and plan for a hospital visit. This means having your advance directives available, printed, ready to bring, phone numbers for your emergency contacts, how to get in touch with your surrogate decision maker, and even practical things. Remember to bring your glasses, hearing aids, dentures, mobility devices, things that could make your experience in the hospital quite a bit better. For those who are at Stanford Healthcare, I just want to remind you that our team is available. You can ask your doctor to place a referral, visit our website, or call our clinic if you're interested in getting connected with us. We're happy to see you, and we have locations in Palo Alto as well as in San Jose. And with that, I just want to thank you all so much for taking time to join us today. I know this has been a lot of information, a lot of things to think about, but we're here and happy to help answer your questions. And with that, I'm going to turn it back over to Ashley Bragg, who's going to help moderate the question and answer session, and welcome Winnie Tudeberg as well, one of our other palliative care physicians, to help answer.
Great. Can you hear me?
Yes, thank you.
Okay. We have some great questions coming in. I'm going to just start at the top with those, with some upvotes. A couple here about pre-existing conditions and how to think about those. So this question is, I'm 66 years old, active and healthy, with high cholesterol and high blood pressure that are controlled by medications. Do these controlled conditions count as underlying health conditions for purposes of determining my risk?
Great. I'm happy to start with that, and Winnie, feel free to jump in. You know, as I described, that those studies where they were looking at those pre-existing conditions really were if you had that sort of as a problem, even if it was well controlled. But I would say that we only sort of have data about those conditions that were listed. So for example, high cholesterol isn't one that we have data about suggesting that that might put you at an increased risk of getting more sick from coronavirus. But there is at least that initial data that suggests that high blood pressure is something that could have you at a slightly increased risk. I don't have more specifics though about how well controlled people were in that study. So this is an area where there is a little bit of uncertainty that continues. But I would say that in general, having those conditions well controlled is a really good thing and probably decreases your overall risk. Dr. Tudeberg, do you have other thoughts about that?
No, I wish that we had more detailed information for you. It's got to be really hard to see a condition that you have on that list. Sometimes talking to your doctor can help too, because your doctor understands a little bit better sort of the degree of your high blood pressure and those sorts of things. But I do agree with you, Grant, that they're just hypertension or high blood pressure in and of itself, according to the data that we have, which is not perfect, does put you at slightly more risk, but we can't really put an exact number on how much.
Right. Okay, this next question is regarding ventilation in the ICU. So if I end up in the ICU on a ventilator, can my family make a decision on my behalf to remove me from the vent and stop heroic efforts to continue my life? How do I arrange that option?
Yeah, thank you for asking that question. And this is a great question, exactly what we are talking about. And that really is sort of now assigning someone who you would want to make those types of medical decisions for you. The ways to sort of do that is, one, to let your healthcare provider know who that person would be. And then I think to help with your family is to talk about the types of situations where you would want to no longer be on a ventilator. And thinking through those scenarios with your family ahead of time can help them sort of have the confidence that they're going to be able to enact your wishes based on what's important to you. So talking with your doctor about it and completing an advance directive where you write down that person's name is an important part of that step.
Great. Okay. I have an advanced directive and I'm considering adding a do not ventilate in the case of COVID-19 clause because I hear that fewer than half of people who are ventilated survive, and you shared some data around ventilation. And those who do not have a significant lasting damage to their lungs or other organs. Would appreciate more info on what to consider here.
I can take this one if you like. So I think that is a really important thing to consider. You know, if you're older and you were to be on a ventilator, the odds of getting better are much lower. And I think there are many people who are considering whether they would want to actually be on a ventilator in the case of a coronavirus infection. I think it is really important to if you want to change your advanced healthcare directive, but I think even more important is to talk to that person who's going to be your surrogate decision maker and make sure that that person knows that this is what you're thinking and that you actually really have a nice, thoughtful conversation explaining why, and even thinking about in what situations, you know, would you or would you not want to have us try to prolong your life. So I know there was a second part of the question, Ashley, if you could repeat that second part, sorry.
No, I read it. Just that they're either people don't survive or they come off with significant long-term damage to their lungs and their other organs. And so just considering all those factors.
Yeah, so that you're absolutely right. So only half of the older people survive, and then those that do, they do often after a very long course of the intensive care unit on breathing machines, sometimes for weeks, and then can come up with chronic, anyone, COVID or no COVID, that's in the intensive care unit on life support for several weeks can often have long-term consequences, chronic scarring to the lungs that can lead to a chronic respiratory issue, weakness. Often people who have been in the intensive care unit need rehabilitation, often a stay in a nursing home for several weeks to months. So it's not as straightforward as going into the ICU and getting better. Even if you were to get better, it's a very long road to recovery afterward. And so that was a great question to think about, what does all that entail? I hope that answers your question. I don't know, Grant, if you'd like to add anything.
No, I would just agree. And actually, I can see that another question is sort of what is quality of life for over 70 and coming off of a ventilator. And just to say that I think, Dr. Tudeberg, what you said is that, again, there's probably a range that an extremely healthy 70-year-old may have a quicker recovery than someone who has multiple underlying conditions, and a 70-year-old who already may have problems with mobility or have underlying lung conditions. So again, there's sort of a range, and I think talking more with your individual doctors about the specifics for you is a good thing to do ahead of time and can help answer some of those, what does this mean for me and my current health status?
Great, thank you. Next, this is a great question. Where should you keep your advanced directive? Should you give it to your regular healthcare provider?
I can take this one, and I would just say that definitely please get that to your healthcare provider. I think it's great to keep a copy with you at home. I would really recommend to, if you were going to the hospital, to bring a copy with you on your person to give to your healthcare providers, even if you've sent it to your healthcare provider or your institution. But really distributing that as widely as you can to the healthcare providers who know you can be extremely helpful, as well as sort of having an on-demand to give to people you are going to meet in a new healthcare setting. I'd also say it can be really helpful to give to your family members so that they have that. If you are for some reason incapacitated, other people have a copy of that they can help give to other people.
Great. Expanding on that, Dr. Tudeberg, this is the perfect question for you. Where do we access advanced healthcare directives? Dr. Smith gave a few examples, and upload them to MyHealth. So for Stanford patients, MyHealth is our patient-facing portal. Can you answer that one?
Sure. So the Prepare for Your Care website that we'll be emailing out to you actually walks you through kind of that tree of life construct that Grant talked about in a really nice way to help you think about what's important help you come to the decisions to put on your advanced healthcare directive, and then it actually helps you create a legal document that you would then sign. So that would be the best place, I think, and that I found most patients like to actually get a new form to fill out. It does technically need to be notarized or signed by 2 witnesses. I know that can be hard in the current situation where everybody is socially distancing. Even having it not signed and notarized is still really helpful for us because it's still outlining your information. And then we actually have a way for you to be able to upload that document once you've filled it out. If you have a way to scan or take a picture of it to upload it into MyHealth, it's in the MyHealth web version. It's not, if you only have MyHealth on your phone, you won't see it, but it is in the web version of MyHealth where you can both see anything that we have on file for you, and then you can upload your document. And we should be able to have instructions for that. I believe we can add that to our website that Grant listed. I know in the message we sent out to all of our Stanford patients, we had those instructions.
Yeah, I would just add that on our palliative care website about advanced care planning, as well as our palliative care website specific to COVID-19, we have instructions that are able to be downloaded directly from there about how to upload it to MyHealth.
Great. This is a tough subjective question, but can you comment on are life-prolonging treatments uncomfortable or painful, such as intubation? And is it so bad that people would refuse these treatments?
It's a great question. I would say that in terms of intubation, being intubated is not thought of as a very comfortable procedure. That being said, throughout if you're hospitalized, we always are trying our best to attend to your comfort. Even if the goal is to prolong your life as long as possible, we don't want you to suffer in pain or have difficulty breathing while we're doing that. I would say that having a breathing tube in place is uncomfortable, and it's uncomfortable enough that almost all people who have a breathing tube in place need to be on medications to help them be able to tolerate the breathing tube. So in general, it's not something that's very comfortable, although we do have ways to try to help to ease the discomfort that comes with being on a ventilator.
Right. Expanding on that a bit, at what point does it make sense to discontinue a ventilator? What are the indicators or criteria for that decision?
That's a great question. And I would just say that, in general, that really depends so much about what those goals and values are. If living as long as possible is important to you based on what you've heard from your doctors about your likelihood of recovering, then continuing to be on a ventilator may make sense. I would say that the question to ask of your doctors and have your family to ask on your behalf is really, what are the chances of recovery and what does recovery look like? And that's why I think it can be hard to sort of make these decisions fully ahead of time, but to start talking about those values and goals and priorities and the type of life you would be willing to live or the things you couldn't live without ahead of time can help answer those questions in real time. I might just see if Dr. Teuteberg has other thoughts to add to that.
I think it really brings back, again, the importance of not just having a paper form, but really talking with the people who will be making those decisions for you. So just so you know, the medical teams taking care of patients in the ICU multiple times a day are talking about how is our patient doing, what are the chances, are the signs looking like this patient is either getting better, getting worse, or staying stable, but not getting better. And, usually when we get close to a week of a patient being stable but not showing signs of improvement, in general, we start to think about maybe we didn't make the right decision. Maybe we should talk with the family and see, is this really aligned with this patient's wishes to keep going after that many days? We do know that patients do show signs, at least, that things it's still going to be a long time on the ventilator, but that they actually there's some glimmers of hope that we could move in the right direction. And so we bring that information to the patient's decision makers and then sort of pair that with how badly how important it was for that person to prolong their life, versus we sort of think of this balance of life prolongation versus seeking comfort. And we try to balance that information together. So again, the more you can talk with your loved ones about what sort of situations would be unbearable or hard for you to imagine living through, and what sort of outcomes you would be okay with. So we also know the longer that someone's on life support, the lower chance they have of coming back to a normal level of function that they would be, able to deal with. So I hear from a lot of people, I don't ever want to be at a nursing home. And patients who are on a ventilator for a long time, even if they get off the ventilator and they live, often do need to be in a nursing home for a period of time. So that's where the medical teams can talk with your family about what we're looking at. Will you get better, and also what will getting better look like, and what will the course look like moving forward. I hope that answers your question.
The next question is from a self-identified worried Stanford student. You shared some data, Dr. Smith, that covers this a bit, but do you have any additional comments on what are the chances of dying or needing ICU level of care for someone who's below 30 years old, has no underlying conditions? The current data in the media is not clear.
Yeah, I would say overall, those chances are very low, that your chances being that young and having no underlying conditions, you're below even those case fatality rates for the general population. So your chances of being in the ICU, being on a ventilator are extremely low. I think in some ways the media probably has covered those stories more than they cover the stories of older adults, because they're sort of so, in some ways, sensational, but they also are very much the outliers in this pandemic. I would just say that, for young people, the most important thing you can do is really to support the rest of the population by sheltering in place, keeping yourself as healthy as possible, but not exposing other people. So I worry for young, healthy people, the thing to worry about is actually the possibility that you transmit either a low asymptomatic disease or a mild case to someone who's at a much higher risk, much more than the risk is that you personally will get very sick or go to the ICU. It's not to say it's not impossible, but that risk is lower than the general population.
Great. If you change your surrogate decision maker, do you have to officially revoke the former choice?
I can answer that one. Just by actually having a conversation with your doctor and saying, I know my advanced healthcare directive says my son is my decision maker, but I want it to be my wife from now on. If your doctor writes that in a note and signs it, that's durable for a couple of months. So that's a good short-term way to do it. The best long-term way to do it is just to fill out a new form. So we don't really go back and invalidate the old ones, but you want to make sure you'd fill out a new form, and then make sure that you send everyone who had a copy of the old form a copy of the new form, just like with a will that you might have signed for financial matters.
Great. Okay, can you comment on how to decide whether someone is critically ill and when to seek medical help? For example, I was told by a friend in healthcare field that monitoring oxygen levels, especially for older folks, is a great way to evaluate how the person's doing. So say if baseline is 90s and the levels are dropping to 80s, is it better to seek medical help early rather than waiting till struggling to breathe?
I can get that one if you want. I've been working very closely with our primary care group at Stanford, and they're also our healthcare teams that staff our express care clinics and urgent care clinics. I would say that if you are sick and if you think that you might have the coronavirus, if at all possible, get tested, because then we know for sure what we're dealing with, but that you seek out medical care. Luckily here in the Bay Area, we are not at any sort of crisis situation. There is healthcare available for everyone. We're able to do video visits with you, telephone calls if you can't get onto video. And for patients who test positive but are not sick enough to come to the hospital, we actually we'll be starting, I believe, in a couple of days, if it hasn't opened already, a special clinic at Stanford for patients who are COVID positive. where we very carefully monitor you, and then a medical team gives you advice. So we're actually sending oxygen monitors out to people's homes. So that's a great question, but I would say absolutely. Oh, you live in Nevada. Sorry, I'm just reading the rest of your question. I think it's worth, I'm looking at someone else's question, I apologize, but I think it's worth to seek medical care, seek the advice of clinicians, and they can walk you through it. So those people that are at home are not sitting home by themselves without guidance from a medical team, at least not here at Stanford.
Great. This next question comes from a patient at our Women's Cancer Center, and she has multiple comorbidities and was sick back in the fall and is wondering if she could have had COVID, and has heard that antibody testing is becoming more available at Stanford. Do you know anything about antibody testing and when it may become available for patients?
I can take that one too, Grant, unless you'd like to answer it.
No, go ahead.
I've been more involved in some of the primary care conversations about this. So we do have an antibody test at Stanford. I know other places are coming up with an antibody test. What we don't know about it is what the answers to the test really mean yet. So we actually, the head of our department just sent out a message to all of our clinicians saying, don't assume that just because your patient has antibodies that they're immune. We don't know that that's going to be how protective that's going to be. We just don't know the data yet. So I know it's got to be scary to be a cancer survivor and living with that uncertainty and being at risk. Again, I think that test is going to be coming much more broad soon to everybody. And I think we'll know a lot more about how to interpret the results. Right now, we don't know. I would say for you, the best thing to do is to really keep yourself as safe as you can by sheltering in place, washing your hands, the things that we have on the screen. If you can get other people to go out for you and do your shopping and things like that, and stay as much as you can out of high-risk conditions would also be our recommendation.
What are the criteria for hospitalization among symptomatic individuals presenting to the ED, the emergency room?
I know neither of us are emergency room providers, but in general, in my experience, when people are coming in with complaints like shortness of breath or difficulty breathing, we really do look at the oxygen level. And if people are needing extra oxygen in order to keep their oxygen levels at a normal level, then that often requires hospitalization for some period of time. But again, it'll be a little bit on a case-by-case basis, but that's sort of in general that the need for additional oxygen is certainly something that means you need to be in the hospital for a little bit of time.
Great. Would approving CPR but not intubation be an inconsistent choice?
Well, I can take that one. Just so you know, so there are many patients who say, and I hear this from patients a lot, I don't want to have a tube down my throat and be on a machine for a long time, but I would want a shot at someone bringing me back with CPR. And I think a lot of those requests come from what we see of sort of CPR on television shows where someone's heart stops and people run in and the quick application of the paddles to their chest and they wake up and they're fine. CPR actually involves both a breathing tube and chest compression, so it's a whole package. What CPR really is taking someone who's died, whose heart has stopped beating, who stopped breathing, and trying to bring those functions back. So it technically, those would be inconsistent. You know, some people feel like they would kind of want a trial of getting better, but might not want long-term intubation. And I think that would be an appropriate thing to put in advanced healthcare directive.
Okay. I'm going to just keep moving. We have a few minutes left. Are electronic signatures via a PDF writer valid if someone witnesses an advanced directive via videos and signs electronically, or does everyone need to physically sign the document?
That's a good question. I'm not sure. Most of them, the way the laws are in California, want a physical signature and a notary. It may be that I know there are some companies that do electronic notary, but I'm not aware of a vendor to tell you. Again, verbal designation of your wishes that's communicated to a physician and documented in the physician's medical record does count and is legally valid. So I think it's important to fill out the forms, send them to us, and talk to your physician if you have new information.
I would just add that I wouldn't want one of my patients not to sort of go through this or fill out an advance directive or think about all these things just because it may be difficult to get a notary. I think that is important when we can do it, but the most important thing is that you think about this, talk with your loved ones, talk with your healthcare provider about what's important to you. So just don't not do this because of that one part.
Does a pneumonia shot give us protection from lung damage? If yes, how long does it take for the limited protection to kick in?
I can take that one unless you want, Grant.
Please go ahead.
So we know that a lot of people who get sick with coronavirus have multiple infections, have coronavirus plus a different kind of pneumonia. So it would protect you from getting a bacterial pneumonia in addition to coronavirus. So it might be protective in that way. I can't tell you the exact time frame, sort of how long after getting the pneumonia shot, but a pneumonia shot in and of itself is only for pneumococcal pneumonia, a specific kind of bacterial pneumonia. So it wouldn't protect you from getting coronavirus, but it would protect you from getting more sick if you were to get coronavirus and a bacterial pneumonia at the same time.
Great. We're at the hour. If we can go 5 more minutes, if you have a few more minutes to answer a few more questions, or we can wrap up. Dr. Smith, Dr. Teuteberg, do you have a few more minutes?
And maybe we can take another one or two questions and then wrap things up.
Okay. The next question is around, is Stanford offering COVID testing? Is the recommendation still only that you get tested if you are very ill versus only if you have a symptom or two?
So I can take that one. So we have many settings. I think we're running several thousand COVID tests a day. And we can, I don't know if we have it in the email we send out after this webinar, but if you were to probably look online or call Stanford Healthcare and ask, we have multiple drive-through testing sites. We are no longer really rationing. In the very beginning, we were rationing the testing because we had so few tests. Now, if someone's sick, basically you can make an appointment and go in and get a test. Obviously, if you just had the sniffles and you felt fine, I would discourage you from getting a test. But if you really felt ill, certainly cough, shortness of breath, or felt really sick, then I think it would be worth doing. But we are not limited by our testing capacity anymore in that way.
Great. If I choose not to go to the hospital and die, how can I make sure in advance that my family is not charged with neglect or refusing help?
What I would say to that question is that, if you feel like after sort of reviewing your current health status and your goals, that coming to the hospital is something that you would not want to do, and that even if you were to get seriously ill and your life were sort of at risk from a serious illness or even from coronavirus, that would be really helpful to talk to your healthcare provider to let them know ahead of time that that's a decision you'd like to make. And then if you were to get more sick or start developing symptoms, reaching back out to that healthcare provider to let them know that they can help provide you support at home and help you think through if the service that we talked about earlier, hospice, might be something that could provide you another layer of support at home to make sure that your symptoms are well managed and treated and that we attend to your comfort as closely as possible. But in general, if you're able to communicate that ahead of time, that is something that no one would sort of be worried about your family having done something to you in that case, if you've communicated your wishes or preferences around that ahead of time.
Building on that, if one is home with hospice, how quickly can they get powerful painkillers during the COVID crisis?
I can answer that. I think having hospice in place, usually someone from hospice can come out the same day and get you enrolled and get the medications you need. It's obviously, it's always better that the sooner hospice can get in there, the more timely they'll be in delivering medication. So if you're feeling ill, if you really think you're getting sick and you know you don't want to come to the hospital, the sooner you can call your doctor's office and ask to get you enrolled in hospice, the better. So we right now are not just sending strong painkillers out to someone's house who's not enrolled in hospice just because there's a lot of safety concerns around that. But I do know from many years of taking care of patients who go to hospice that we can usually get a team out there to get you enrolled in hospice the same day and get the medications that you need.
Are there problems around having more than one person as a surrogate decision maker?
What I would say to that is that we know that families all make decisions in different ways. Sometimes it can be helpful to have one person who is identified as the person who will sort of be the tiebreaker, for example, if there was conflict within a family about what to do. But we do try to honor as much as possible those families who feel like having multiple people have input to their healthcare decisions is important. And we work really hard to try to build consensus among family members when there is a larger group of people making a decision on someone's behalf. However, I do think it can be helpful that if you're able to provide a single individual who would be the person that would step up in the event that there was discourse or disagreement among multiple individuals.
Great.
Ashley,
All right.
I'm wondering if it might be helpful for us, just because of time, I want to respect our participants
Yeah.
as well, just to wrap up and let people know what to expect kind of in their email.
Great. Yes. Thank you, everybody, for joining us. We still have a number of unanswered questions, which leads me to believe that we should consider a future webinar or even some office hours with some of our palliative care team members. So please stay tuned for some future communication from us. You'll receive a survey in your email. Please take a few minutes to complete that. It'll include these links we've talked about today. Please check out our new website, which has all of these resources and more, as well as an opportunity to reach out to our team for education and other needs that you might have within, say, your employer or a community setting. So we're happy to come to you and tell you more. So thank you so much for your time today. And everyone, please wash your hands and take care.
Thank you. Thank you, Ashley. Thank you, everyone, for joining us.
Thank you.
Thank you, everyone.